Okay, let's dive right in. Welcome back to another explainer. Today, we're looking at the high-stakes, literal life-or-death balance of the human clotting cascade and exactly how we manipulate it on the operating table.
You know, transfusion really is a double-edged sword. It's an absolutely vital lifeline, for sure, but one that carries some incredibly hidden, microscopic dangers. So we're going to treat each of these clinical scenarios as a medical mystery to solve. We'll explore the science of surgical hemostasis through a series of rapid-fire questions drawn directly from our source material. Let's get into it.
Section 1. Pharmacological bleeding control.
All right, imagine a trauma patient bleeding out on the table. We need to know exactly how tranexamic acid, or TXA, stops this hyperfibrinolysis. So what's its mechanism of action? Does it directly inhibit thrombin, competitively inhibit the activation of plasminogen by binding its lysine binding sites, maybe act as a structural analog of vitamin K? Or does it proteolytically degrade circulating fibrin split products?
Well, the correct answer here is B. TXA is a powerful anti-fibrinolytic agent. It basically functions as a synthetic lysine analog that competitively blocks the lysine binding sites on plasminogen. This effectively prevents plasminogen from binding to fibrin, which stops its activation into plasmin. The big takeaway here? TXA doesn't actually create new clots. Instead, it acts like a shield, protecting the clot you've already managed to form from being prematurely dissolved.
Moving right along to our next scenario. What if the platelets are physically present but functionally useless? Here's the question. A 65-year-old male with chronic kidney disease requires an urgent hemicolectomy for acute diverticulitis. He has a perfectly normal platelet count, normal PT, and normal APTT, but a markedly prolonged bleeding time due to uremic platelet dysfunction. What's the most appropriate initial treatment to get his hemostatic function back on track before surgery? Transfusion of random donor platelets, administration of desmopressin, infusion of unfractionated heparin, or maybe recombinant factor 7A?
The correct answer is B, giving desmopressin, which we also know as DDAVP. And here's the crucial clinical pearl for you. You need exactly 0.3 micrograms per kilogram of this drug to make this happen.
This actually perfectly illustrates why simply giving him new platelets is a terrible idea. Patients with significant uremia experience severe, qualitative platelet dysfunction. If you just transfuse brand new platelets, they're going to quickly become just as dysfunctional in that toxic uremic environment. It's a waste. Instead, that specific DDAVP dose forces the immediate release of the patient's own endogenous von Willebrand factor and factor VIII directly from endothelial storage sites, specifically the Weibel-Palade bodies. This temporarily, but very effectively, corrects the bleeding issue within a few hours so you can actually operate safely.
Section 2. Diagnosing coagulation deficits.
Now, this brings us to thromboelastograms, or TEGs. These are absolutely incredible because they give us a real-time, moving visual of clot formation. So, the question asks, which component of a TEG profile represents the time from initial sample placement until the first detectable fibrin clot formation, and which blood component should you transfuse if this specific value is prolonged? Is it the alpha angle treated with platelets, the maximum amplitude treated with cryoprecipitate, the R value treated with fresh frozen plasma, or LY30 treated with aminocoperic acid?
If you look at the breakdown here, the correct answer is C. The R value, or reaction time, measures the exact time required for initial enzymatic fibrin formation. If that R value is prolonged, it's pointing a giant red arrow directly at a deficiency in circulating coagulation factors. And that means you need to treat it with fresh frozen plasma, or FFP. Notice how the rest of this maps out, too. The alpha angle deals with the rate of clot kinetics, so you need cryoprecipitate, while the maximum amplitude deals with absolute clot strength, which means you need platelets.
Let's tackle the next scenario and see how this all builds into targeted component therapy, specifically when your fluid volume is heavily restricted. The question is, cryoprecipitate is an ideal source for rapid, volume-restricted replacement of which of the following coagulation components? Is it factors 2, 7, 9, and 10? Protein C, protein S, and antithrombin 3? Fibrinogen, von Willebrand factor, and factor VIII? Or albumin and gamma globulins?
Okay, the answer is C. Cryoprecipitate is this highly concentrated source of fibrinogen, von Willebrand factor, factor VIII, and factor 13. Literally, it's prepared by thawing fresh frozen plasma at exactly 4 degrees Celsius and collecting the cold, insoluble precipitate that forms. It is just the absolute perfect concentrated treatment for surgical patients who need severe hypofibrinogenemia corrected, especially when their fibrinogen levels tank below 150 milligrams per deciliter.
Section 3. The risks of the lifeline.
Look, Giving blood isn't just some magical, side effects-free cure. It introduces massive and sometimes really hazardous chemical shifts into the body. We call these structural and metabolic changes storage lesions. Basically, it's the biochemical alterations that happen while the blood is just literally sitting on a shelf in the blood bank. So, the question is, which of the following does not occur over time in stored packed red blood cells? Decreased 2,3-DPG? Increased extracellular potassium, increased intracellular ATP, or the accumulation of pro-inflammatory microparticles?
Actually, the false statement is C, because intracellular ATP actually decreases over time. During prolonged storage, red blood cells suffer this steady, relentless depletion of metabolic substrates. This causes a marked drop in both ATP and 2,3-DPG. Now, that loss of 2,3-DPG is absolutely critical because it shifts the oxygen-hemoglobin dissociation curve to the left, which ironically means it reduces tissue oxygen delivery. On top of that, because the ATP-dependent pumps fail without energy, dangerous extracellular potassium actively leaks out into the storage media.
And that chemical imbalance leads right into our next clinical emergency. Imagine a patient in severe hemorrhagic shock receiving a massive transfusion protocol. Suddenly, out of nowhere, they develop a prolonged QT interval on their ECG, muscle fasciculations, and a really dangerous decrease in systemic vascular resistance. What's the underlying cause here? Is it hyperkalemia from red cell lysis, citrate toxicity binding ionized calcium, an acute hemolytic reaction, or severe metabolic acidosis?
The answer here is B, citrate toxicity. You see, blood products, particularly FFP and platelets, contain high concentrations of sodium citrate as an anticoagulant preservative. If you're rapidly pumping in high volumes of blood, you completely overwhelm the liver's capacity to clear that citrate. This free citrate then starts binding or chelating the patient's circulating ionized calcium, causing acute hypocalcemia. That sudden drop in calcium is exactly what explains the life-threatening myocardial depression, the hypotension, and of course that prolonged QT interval.
Section 4. Severe transfusion complications. So, the storage environment itself presents these hidden, sometimes fatal, dangers. This next scenario is a heavily tested concept, mainly because it defies a lot of older assumptions. Which blood transfusion complication represents the leading cause of transfusion-related infectious mortality in the United States today? Is it the transmission of HIV, hepatitis C, bacterial contamination and sepsis, or West Nile virus?
Well, viral screening is absolutely excellent today. So the real threat actually lies hidden behind this exact temperature reading, 24 degrees Celsius. To preserve their functional activity, platelets simply cannot be refrigerated. They have to be stored at a relatively warm 20 to 24 degrees Celsius.
And because of this warm temperature requirement, the correct answer is C, bacterial contamination and sepsis. This is specifically tied to platelet transfusions. That room temperature storage acts as a perfect little incubator, allowing for rapid bacterial growth if even a tiny bit of contamination occurs. Meanwhile, the risks of transmitting viruses like HIV or hepatitis C are now extraordinarily low, all thanks to rigorous nucleic acid testing. Finally, let's look at a genuinely terrifying respiratory complication that can happen even with a single unit of blood. A 35-year-old multipara female receives 1 unit of PRBCs during an elective procedure. Just 2 hours later, she develops acute hypoxemia, tachypnea, fever, and a cough. Her chest X-ray shows bilateral pulmonary infiltrates, but, and this is crucial, her capillary wedge pressure is totally normal. That means this isn't volume overload. What is the most likely diagnosis? TACO, TRALI, ARDS, or an anaphylactic reaction?
The answer is B, TRALI, or transfusion-related acute lung injury. Notice the criteria here. It's a sudden, non-cardiogenic pulmonary edema happening within 6 hours of a transfusion. It's primarily mediated by donor-derived anti-leukocyte antibodies reacting with host neutrophils right there in the pulmonary microvasculature. And the massive clinical pearl you need to remember? This carries a uniquely high risk when the donor is a multiparous female, meaning she's had multiple pregnancies, due to the alloimmunization that naturally occurs during gestation.
Wow, we've unpacked a massive amount of clinical data today, mapping out everything from the antifibrinolytic defenses of TXA to the literal cellular dangers lurking in stored blood. This incredible balancing act between saving a life and triggering a cascade of complications leaves us with one really provocative thought to ponder for the future of medicine. If the life-saving act of a transfusion inherently carries risks of acute hypocalcemia, bacterial sepsis, and sudden lung injury, how long until we rely entirely on purely synthetic, side-effect-free artificial blood? It's a fascinating horizon to watch, for sure.
Thank you for diving into these mysteries with me today. And as always, keep questioning everything.